Dr. Kimberly Spiro has been with Oregon Health and Science University since 2011. She's the co-developer and clinical director of Novel Interventions in Children's Healthcare, or NICH, a population health program specializing in caring for children with special healthcare needs, living in underserved families experiencing high degrees of social vulnerability. NICH targets the social determinants of health, integrating evidence-based techniques to address individual, family, and system-level variables impacting effective health management and adherence. Prior to her work at OHSU, Dr. Spiro worked as a research scientist and clinician at the Oregon Social Learning Center in Eugene, Oregon, where she focused on the treatment of youth involved in the child welfare and juvenile justice systems. She spent her career working with highly vulnerable children in both the medical and community mental health settings and feels passionate about issues related to health equity and social justice. Please join me in welcoming Dr. Kimberly Spiro.
Hi there, I am Dr. Kimberly Spiro, and I'm on faculty at OHSU in the Department of Psychology. I am the co-founder and clinical director of the NICH program. NICH stands for Novel Interventions in Children's Healthcare, and it was developed by myself and Dr. Michael Harris at OHSU. And today I'm going to talk with you about keeping the ship afloat, strategies for engagement that work for anyone. I'm going to talk about that population of patients that keep slipping through the cracks, the families that you may be most concerned about, who you refer for support services, and for one reason or another, they're not following through and they're simply not engaging. So today we're going to talk about lessons learned from NICH. So just a little bit about me. Before I joined faculty at OHSU, I spent the first 25 years of my career working at the Oregon Social Learning Center in Eugene, Oregon as part of a research and treatment team, developing interventions for juvenile offenders and traumatized kids in the foster care system. And through all those years, I learned firsthand experience to some of the outcomes and experiences that RJ had talked about in his talk. Those intergenerational cycles of complex social issues and social inequities that impact families and impact child development and impact school outcomes and health outcomes. It's easy to see when you're working with these families, the way these complex social risk factors really affect family functioning and how kids who are raised in these contexts are really set up to struggle. That without intensive intervention, it's really hard to break those intergenerational cycles. And that children who are raised in these families and are set up to struggle become parents who continue to struggle, and the cycle continues. I was fortunate enough through those years of working at OSLC to learn a bunch of evidence-based intervention strategies for working with these families and to help break those cycles. And after my work there, I ended up moving to Portland and met Michael Harris. He's the chair of pediatric psychology at OHSU, and together we developed NICH. So NICH was developed really in response to this population of kids who are repeatedly hospitalized because of non-adherence with their medical regimen. Kids who have complex and chronic medical conditions who are really struggling managing their health because their families are heaped under just a mound of psychosocial stressors that's impacting caregivers' ability to effectively support kids. And Michael kept seeing these kids who kept coming back to the hospital who were referred for services. Excellent case managers and social workers would refer these patients for really good services in our community. And families just either weren't following through or simply weren't able to engage or make use of the services that they were being offered. And the kids kept coming back to the hospital. So that's what I'm going to talk with you about today. We developed Niche in response to that problem. And I'm hoping that some of the things that we learned from Niche will be, for some of you, refreshers to what you already know. And for some of you, maybe you can take some pearls away and it can enhance what you're already doing to help get the services to the kids who really need it. So really quickly, just Niche in a nutshell, it was developed to address the triple aim of Medicaid reform, to improve health outcomes and improve care and reduce costs for the population, the Medicaid population that's using a lot of the resources. So it's an intensive intervention program designed for underserved families, as I mentioned, of kids with complex and chronic medical conditions who are struggling with suboptimal adherence. Niche is really intensive. It provides 24/7 intensive skills training and support for these families. And it really takes a two-prong approach. We really focus on addressing those social determinants of health, helping families stabilize their lives, and at the same time providing really intensive skills training and coaching to give families the skills they need to effectively navigate the medical system, to effectively parent their children, and to get their kids to cooperate with following their medical regimen. Niche has now served over 300 patients over the last 8 years, and we really have addressed the triple aim. We've had great outcomes for reduction in utilization and improved health outcomes for these kids with complex and chronic medical conditions, and really improved provider relationships with these families where sometimes there's been a breakdown between the family and the medical team. And these are families where providers have really felt hopeless about really how to get families the help they need, and it has improved their sense of self-efficacy. So I want to give you that background around Niche, because that's really where I'm drawing the strategies that I'll be sharing with you today through a couple of case examples. So what we already know, you heard from RJ's talk about the percentages of families with high ACE scores and all of the negative impacts for those children across school and health and general functioning. So we know that there are a significant number of families who need services, and you can probably all think of some families that you feel like you've referred and you know how desperately they need those services, and they're simply not following through. So I'll just a little caveat, when I first started working with Niche 8 years ago and we treated our first 20 patients, I thought, well, I guess we're done. How many can there be? How many families can there be with kids who have complex and chronic medical conditions who are being referred to services and not following through? Our community has outstanding evidence-based services. We have great community health workers and great case managers and social workers, and these families have to be getting their needs met. And what I can tell you is that there are a lot. We have had over 300 referrals last year alone for Niche, and they only get referred to Niche when all other support options have failed. So if in 1 year we've had 300, I think that, I stopped being convinced that I was going to work myself out of a job by treating these families, because I've now become, I've started referring to this population as the invisible population. I think that people really are not aware of just how many families are dealing with high degrees of really social complexities and years of inequities that are impacting their ability to engage with services that they really need. So I'll just say again, there's a significant number of families who need help. The services exist. We have really outstanding and caring providers who identify that families need help, and they refer to those evidence-based programs that are available. And yet there's kids who are slipping through the cracks. So what are those cracks? And why aren't some families engaging in services that they need? So the reason, I think I'm probably preaching to the choir here, everyone knows about the social determinants of health. RJ just spoke about all of, again, those intergenerational cycles that we know about of inequity, families with significant trauma histories that impact daily functioning. And we know that families can end up having a negative experience. They feel marginalized and discriminated by the healthcare system, even by well-intentioned people. I think that many of these families, when they're dealing with housing and food insecurity and domestic violence and abuse, really they're in part not in engaging because these families are living in survival mode, and really acuity drives action. So when you're considering how you're going to put food on the table for your family, or whether or not, if you're in a domestic violence situation and your partner is going to come home, and whether or not you're going to be beat, or if you have a crisis because you're worried you're going to get evicted, or you're in the midst of houselessness. Those things really, they take priority, and a child's health moves down on the priority list, not because families don't care, not because caregivers don't want to get the help that they need for their child, really because there are more acute problems that they're dealing with. And I know about the way cortisol affects functioning. And I think so many of these families with these histories, parents with histories of trauma, still living in really complex social situations, they're living moment by moment, and their brains are probably soaked in cortisol, and it's really hard to be planful and to follow through when that's the situation. Lastly, I think one of the cracks is there's a diffusion of responsibility. And what I mean by that is, like I said, we have amazing social workers and care coordinators that make referrals for families, but when they don't follow through, then what happens? We make the referrals again. I think we're really good at making referrals. And then if patients don't follow through, who ultimately takes responsibility to actually problem solve and overcome whatever the barriers are, joining with the family? And I think the concept of the medical home model really assigns responsibility to primary care. And I think that primary care has taken that on, but what do you do when families won't engage? And what do you do when they don't follow through? So that's what we're going to talk about today. So the metaphor for why families don't engage that I think of is this iceberg. Families are slipping through the cracks because providers oftentimes see the top of the iceberg. And really, there is an entire full picture of greater social complexity that providers don't know about, and that base of the iceberg, those are really the barriers to engagement. And our healthcare system is really set up to focus on what families have to do. So you see the tip of the iceberg, and you give families, here's what's going to help you, and to get things back on track. And we spend less time focused on the how families actually have to accomplish those things, and maybe even less focused on the why, and why are families not able to do the things that we believe are going to help them to address issues. So in order to get families the help they need, we have to address the why and consider the ways that the why is impacting the what and the how. And in order to address them, you have to know about them. And in order to get the full picture, it really comes down to engagement. So actually on this slide, I previously had a little Titanic approaching the iceberg, and the Titanic in my metaphor was this state-of-the-art healthcare system. and with behavioral health and mental health and all these amazing support services. And I had the Titanic hitting the base of the iceberg and then sinking to the bottom, because I think that when you don't see the full picture, it doesn't matter if you have evidence-based treatments and state-of-the-art services to offer families. But anyway, my husband gave me feedback that I didn't need to include the Titanic, so I'm just telling you about it. I kind of thought it was clever. So where the rubber meets the road, this is what I'm going to talk about today, is really what are the skills of engagement for those families that won't engage. And I'm going to walk you through some case examples based on how we do it in niche. It's not rocket science, but it takes time, and it takes nuance, and it takes follow-up. So today we're going to talk about how do you get the full story, and it requires the shift in perspective to really appreciate the true challenges that families face, not just the tip of the iceberg where you are already worried, but appreciating those barriers. How do you target those social determinants of health, and how do you assess, can families, I think about the can and the will they, how do you assess, can families do the things that we're asking them to do? And the can is, do they actually have the resources to be able to do it? And the will they is do they have the skills, and also are they so overwhelmed that it's actually just too much and they're not likely to? So, and then how do you scaffold support? So in niche, we have a model where we talk about doing things for families, with them, supporting them doing it themselves until they can do it themselves. So for you, with you, support you until you can do it independently. And we scaffold the kind of support that we offer based on the can they and will they. And if families are too overwhelmed, then we need to do things for them to actually be the bridge to connect them to the services they need. And then how do you reinforce all the small wins? Even if families aren't following through, there's lots that they're doing, even if they're just picking up the phone to talk to you. And almost to an uncomfortable level, we need to provide a really high degree of reinforcement for these families, appreciating their true challenges. Yeah, to see if I have some water here. I believe I do. Bear with me. Okay, so here's our first patient. I'm going to walk you through some case examples and really highlight the things that we've learned from niche. Let me first introduce you to Danielle. Danielle is a 14-year-old girl with poorly controlled type 1 diabetes. She had a high A1C above 13. She had 3 DKAs in the last year. She lives with her grandma. Grandma presents as really kind of gruff and mean towards Danielle. She comes across as irritable during appointments, and she reports that they fight all the time, and she can't get Danielle to cooperate with her diabetes regimen as well as other things. Danielle's not consistently attending school. They had missed their last appointment, and grandma canceled at the 11th hour last minute. You really, as a provider, this is what the provider sees, felt like they could use counseling. They needed some support and help, but grandma wasn't following through with the referral. So I ask you to think for a minute. You probably all have patients like this. And when you begin to have concerns, you refer the family for services, and the family isn't following through, and the patient is getting sick. And I guess I want you to stop for a second and just think about, what are your thoughts about a family like this? Do you ever find yourself judging the caregiver, especially one that presents as gruff and angry and irritable? Do you ever find yourself blaming the caregiver for the youth's behaviors? Do you ever think to yourself, why can't they just make the call to get the help that they need? Why can't they just follow those recommendations that we're giving? Imagine one of your families that you're worried about isn't following through, and then I think it's good to consider, what do you think grandma's experience might be like when she comes to see you? Or you call to follow up on whether or not she followed through on appointments, and you get on the phone and you say, hey, I'm just calling to see if you were able to make that appointment, and grandma hasn't done it. So I think it's important to imagine how grandma feels. And the feedback we've been giving from niche families is oftentimes parents feel embarrassed and they feel judged. And I'll say, when you're living with this iceberg, I think that, again, even the most well-intentioned people in interactions, I think families can feel that the world is unfriendly and uncomfortable and unkind and overwhelming. And most of the experiences a family like this has with the medical system, is that they feel judged and blamed. So usually what the medical system has to offer is expectations, because referrals require follow through. Make this call, schedule this appointment, show up for this appointment, work your work schedule around these things. And I can say that even the most simple of expectations can feel overwhelming when you're already overwhelmed. I mean, I'll be honest that I'm a mother of four, and I have a two-parent household it's resource rich. But even just managing my own kids' dental and medical appointments and sports, and as well as my own self-care and needs, the weeks that I have to squeeze in one extra appointment for either them or myself, I can feel overwhelmed. So I think we can all agree that the way life operates today, we're all kind of burning the candle at both ends. And again, I'm someone who is well resourced and not experiencing a high degree of social vulnerability. Maybe you can relate to that. So the first step is to tailor engagement. And in one of the things we've learned from Niche is, when you call a family who is already not followed through with referrals, then you want to be extra sensitive. And the way that you engage them around that, there's a lot of nuances to doing that effectively. So I'm going to walk you through this first case example with a lot of detail. And then for the next case examples, I'm going to go a little bit quicker, just in the interest of time. Again, you are probably doing many of the things that I'm recommending here. So if you are, you can just like pat yourself on the back and say, great, I'm doing it. And I'm guessing that you probably are getting a pretty good degree of follow through from your families. And if you're not, then maybe there's, again, some skills that I'm going to be talking about that will help you to get the full picture. So the first step is really to gather information, because we want to gather information from everyone who knows the family, because we want to frame the outreach. We want to frame the call so we can get a little buy-in. So then in this situation, as we after you frame your role, then you really want to tailor not just this situation, you want to tailor your engagement to a way that you think the family is most likely to buy in and hear what you're saying. So in this situation in particular, the provider shared that the patient had moved in with her grandmother last spring. Danielle moved in, and grandmother said that she'd come from parents who could no longer care for her. Grandma seemed really stressed out because she couldn't get Danielle to cooperate. And the provider believed that grandma had a job and she felt like things were pretty stable and she had resources, but she knew that there was a really high degree of conflict, and she really felt like the family could benefit from individual and family therapy. That was suggested to grandma, and grandma wasn't following through. So if you're going to make a call to someone like this, I'll share with you what our interventionist said. Our interventionist, first, when grandma answered, and this is a little weird, I'm just going to share some scripts with you, because I think that the devil is in the details, and the words that you use and the ways those interactions and conversations happen really matter. So here's my phone call. Thank you so much for taking my call. I spoke with Dr. Baskin, and she shared a little about Danielle and really how she's been struggling with her diabetes management. She also shared that she believes that you're doing everything that you can, and it sounds like you really have your hands full. I know how challenging it is managing type 1 diabetes, and I can only imagine how stressful this is for you. I'm wondering how you're doing and if everything's going okay. So as you would imagine, grandma reported that things were really stressful and she wasn't sure how much longer she could do it. So the the response to that might be that I've been doing this for a while, and I work with a lot of families with type 1 diabetes. And what I hear from all of those families are that it's really stressful and that oftentimes they feel isolated. And I'm wondering if you can relate to some of these feelings. And grandma, of course, can relate to those feelings. So instead of immediately jumping to problem solving with grandma and offering support, just helping her to feel like she had the space to be able to talk more about it, helping her to feel normal, and giving her a sense that we really cared about how she was doing really did open the door, and we learned a lot more about grandma's situation. So what we learned was that Danielle had been abandoned by her parents who had substance abuse issues. She was dropped off at school one day in the spring, and her parents refused to go and get her. They called grandma, and they basically told grandma, if you don't come and get her, then she's going to end up in foster care because we are done with her. She had a trauma history, and she had been emotionally and physically abused, and she had witnessed a lot of domestic violence. Grandma had her own trauma history, and she really had watched her children suffer as a result of her own experiences with domestic violence and then getting into substance use themselves. And she, because of that, really felt extra committed to essentially help rescue Danielle from a similar outcome. Because of Danielle's trauma, grandma said Danielle acted out all the time. She was taking off. She was running away. Grandma couldn't get her to go to school consistently, and that really there was just a really high degree of conflict. Lastly, grandma shared that her partner, she had had a partner who moved out about 2 months prior because of the high degree of conflict in the house. So now grandma is dealing with this kid who is getting sick. Grandma is having to take her to the hospital. People are making referrals. Grandma feels like she can't get Danielle to cooperate with anything. So the idea of getting Danielle to go for therapy felt like out of range for what grandma was dealing with. So if you can now try to imagine being in grandma's shoes, you're trying to save your granddaughter from foster care and turn her life around. You're doing everything that you can. You lost your partner. Danielle keeps getting sick. And at this point, grandma really felt like she was at her wit's end and she was ready to give up. And that's what she reported. This call lasted about 25 minutes. And we really learned the base of this iceberg and what the real barriers were. So now I guess I just like to ask you to reflect for a minute. How does this information really change your perspective from what you had previously thought about this family and your judgment of grandma, if you had judgment? And think about how these stressors and what you've now learned likely are impacting grandma's ability to follow through. And I guess, what do you think now about what her experience might be when she comes to see you, or when you ask her about adherence and about following up for counseling? So again, the devil is in the details. So this may seem like overkill. And again, you may already know these skills. But the next part is the prescription for how in niche we respond to stories like this. So this is the prescription. You validate, you legitimize, you reassure, and then you assess if basic needs are being met. So here's some scripts for that in this situation. To validate, our interventionist said, wow, I can only imagine how stressful that is and why you feel really overwhelmed. I have to say, I really appreciate you just taking my call today, given all that you have going on. And I can tell that you're really worried about Danielle, and you want to keep her safe, and you're committed to keeping her in your care, but you really feel like what you're doing isn't helping. And I understand why you feel like you're ready to give up. As you can imagine, that was very validating. Grandma agreed. She actually opened up more after that and shared more detail about what her struggle was like. Um, Moving on, this is a really important step, is the legitimizing, is actually saying, I understand why, if you have all of these things going on, you haven't followed through with the referral for counseling. You're the expert on your kid and you believe that you can't get her to cooperate with anything. You're already fighting with her all the time. You've suggested counseling before and she explodes. So the likelihood of her going is, grandma believes, almost impossible. So it's understandable, and you want to make sure you legitimize, because that's, again, just more validation for grandma's situation. And then you want to reassure that there actually is help, but you want to do this, again, in some nuanced way. So reassurance might sound like, I can also imagine that you've come this far. Like you said, you've taken her in, and I bet there's nothing that you would want more than to get Danielle the help that she so desperately needs. And I hear that you don't want to be another adult that's giving up on her. It really feels like you could use some support. And even though I know that you feel like Danielle wouldn't go, I'm wondering if it might help for you to talk to someone that has expertise in dealing with kids like Danielle, who might be able to coach you in how to get Danielle to go. Maybe not right away, but maybe eventually. And I'm not that kind of expert, but I know that those people exist. I know there are those right people, and that's something I can help with right now. So the other piece to this is to try to figure out what you can do and what you can offer right now. For this family, her basic needs were met, but we didn't know that. And so we always want to ask and make sure. So in every one of these calls, when folks aren't following through with referrals, we don't want to make any assumptions. So we like to actually straight up ask the question, hey, one of the things I like to ask every family that I'm talking with is whether or not their basic needs are being met. Things like, making sure you have secure housing and that you're not worried about food. And if you're comfortable talking about that with me, I'd really love to be able to help with that if I can. So when you straight up ask those questions and you're really kind about it and you've already allowed families to share a lot, then it's not uncommon that families will tell you. In this situation, grandma had all of her basic needs met, although she was worried about losing her job because she had to take time off repeatedly when Danielle would become sick or when she would call in a crisis and need medical supplies. So she was anxious about that. So the next step is you got to develop a plan. You have to assess the likelihood that the family will follow through. This is that can they and will they part. Do they have the resource to do it? Do they have the skills to do it? And are they too overwhelmed to do it? And then you have to do that for them, with them, support them assessment, and break things down into small steps and figure out what parts you need to do and what parts you think they will actually follow through with. And then you have to make it happen. And there's it can require a lot of time, energy, and effort to do the back end work to figure out how to make a plan happen that increases the likelihood that a family will follow through. And then you have to check in regularly. So I'm going to keep talking through this one example with a lot of detail just to really flesh out the details. So developing a plan might sound like, hey, picking up on that last conversation with grandma, I know of some amazing counselors that specialize in supporting kids and working with kids like Danielle with trauma histories, and some who work with kids who specialize in supporting kids with type 1 diabetes. I'm thinking that a place that could cover everything, support for you and potentially Danielle, even if she won't go right away, would probably be ideal for you. And I'd like to try to find one that's nearby your house. That would be the developing a plan, but then the assessing the likelihood of follow through might sound something like, because we already know that grandma has resources, we don't really have to assess whether or not she can, but we did want to assess whether or not she would. So it may sound something like, I know you're incredibly busy dealing with a ton of stress, and I'm wondering, and I really need you to be honest with me. If I were to find the right place that I believe could help you to strategize how to get Danielle in for counseling, would you be able to make it to an appointment once a week? And I think so often we just refer and we expect that families can do it, and straight up asking whether or not it's likely that they can do it. And it's okay saying it's okay if you can't, because I don't want to make a referral for something that you can't follow through with, because that's not going to be very helpful for you. And so in this situation, grandma said yes, that she could. And we really thanked her again for sharing her situation. We then did a ton of reinforcement that it takes a lot of courage for her to share her experiences. We thanked her for trusting us with that information. And then we promised her, we reassured her that we're going to do everything we can to find the right kind of support. We reassured her that we know that there are great options in Portland, and that we were going to find the right thing, and that we were going to do some research and call her back. So that was the developing a plan with grandma, but then you actually have to make it happen. And again, where the rubber meets the road around this is in the details. So to find the right match, we actually had to call around and we had to talk to a bunch of places. When we did find the place that we thought would meet grandma's needs, that wasn't too far away, that actually would do in-home services, that would go out to her house, and we really felt like that was going to be what was going to work best. Then we wanted to prepare the therapist, because we wanted that from the first time grandma had a session with them, that they could pick up reassuring grandma. So we kind of did a warm handoff to the therapist. It wasn't like we expected that we were going to call grandma back and tell her, here, these people are going to help you, call and schedule an appointment, and then she was going to go and find it helpful. So instead, we did this warm handoff. We spoke with the therapist beforehand. We gave them the background story. We let them know that we didn't think grandma could tolerate too many sessions where things weren't improving, and that they were going to have to do a lot of reassurance. And they did. And it was fantastic. We ended up calling grandma back. We told her that we found the right place. We told her that we handpicked a therapist that we spoke with that we thought was going to take really good care of her. And then we made the call to schedule together, because we really believed when we did that assessment of can they, will they, that grandma was too overwhelmed and she wasn't going to follow through. So we actually did call together. We made the appointment, and grandma went in. And the last part is the checkup and the follow through. And so we did let grandma know, if it's okay with you, we'd love to hear how it goes. So from primary care, you could do this. Someone in a primary care office could certainly step in and use these strategies. It does take time. It does take extra, back end work, and it does take some nuance, but it's doable, and it's really it's these nuances and this extra time, energy, and effort that ends up allowing the bridge to be made between families, not just we know they need the support, but actually going in and getting the services they need. So the last part that I recommend is actually, if you were the one that connected grandma with the services, I'd put a reminder in my phone to call the day before and check in with grandma and say, hey, I'm really excited for you. Tomorrow you're going to meet whoever it is. And I'm excited because I really think they're going to be able to help you. And I just wanted to call and make sure that appointment is still going to work for you and that things haven't come up, because if they have, let's problem solve it. And in this situation, I think those calls the day before are really good reminders. And if something did come up, then you don't have to wait with the family canceling last minute. I think that it shows that you care. It demonstrates your commitment, and it's encouragement for the family to actually follow through. That last step then is to say, and I can't wait to hear how it goes, and call the day of the appointment. So grandma goes to the appointment, and we called afterwards and we said, tell me how it went. What was that like? And then if a family is discouraged or it feels like the services aren't meeting their needs, you know, and you can right away deal with those problems. I think oftentimes what we know about therapy is it's like 40% of people who go for one session and then never go back again. And if we don't actually call and follow up immediately, it's possible that family never goes back and you don't know until the next time you see them, or you wait a week. And after a week of grandma feeling like that is not going to work for me, it increases the likelihood that she's more discouraged and she's not going to follow through. So one of the nuances to all of this is someone needs to be, when I say take responsibility, someone has to be the relationship holder to communicate with grandma regularly and to check in about how it's going, to problem solve. So I got to check how I'm doing on time. I'm doing okay on time, it sounds like. Okay, I'm gonna keep going. Here's another case, okay, just to give you another idea. And now I'm not gonna go through all those details, but I hope that those nuances came across, and hopefully, again, can enhance and improve your ability to get families the services they need. Okay, so this next case, this is a 4-year-old little boy named Pedro. He has failure to thrive, and such significant failure to thrive that he had an NG tube placed. So he was also being fed through the NG tube. This was a Spanish-speaking family, and mom reported to the provider tons of behavior problems. She felt like Pedro had a lot of tantrums and he wasn't cooperating around eating. There were actually multiple ED visits because Pedro kept pulling the NG tube out, and mom couldn't get him to cooperate to put it back in herself, although she had been trained. They had no-shows to appointments, and they had been referred to the feeding clinic at OHSU, and had been referred to early intervention services, and had been referred to PCIT, parent-child interaction therapy, all those good support services that we thought would really benefit this family, and they were not following through. So we got to tailor engagement. So in this one, I'll go through it really, really quickly. We learned a little bit more from the PCP's perspective, and then we had to frame how we were going to introduce our support to mom. So in this situation, if you don't speak Spanish, then you have to use interpreter services. One of those little tricks of the trade that Niche does is we get an interpreter on the phone 15 minutes ahead of time, and we bring them up to speed on what our goal of the conversation is. So they have an idea, and they're on board with what our plan is. And in this situation, our plan was just to try to get an understanding of things from mom's perspective about what she was really experiencing on a day-to-day basis and how much of a challenge things were. So a really quick call might sound something like, hey, I wanted to check in to see with you, to see how Pedro's been doing. I know you've been doing everything you can to try to get him to eat, and I can imagine how stressful it must be and how worried you are. I know that sounds really basic to say something like that, but it's one thing to call and ask, how's it going, and how are you doing, rather than, is Pedro eating? Because we don't want grandma to already feel like mom to feel like she's already failed. So in this situation, mom shared her story, and what we learned was that she was doing everything she could to get him to eat, and that when she tried, he refused and he had tantrums. Of course, we responded with empathy and validation, and we reassured her again that we knew that she was doing everything she could. When we asked more about what it was like and why she thought that he wasn't eating, that's when she really opened up. So that little twist to the question, instead of he's not eating, what are you doing to get him to eat? And then telling her more of what she needs to do, we focused on the why. Why do you think that he's not eating? And that's when she shared that her daughter had been, her husband had been abusive to her and to the kids, that her daughter had been sexually abused, that he fled the country to avoid prosecution. The kids had witnessed, obviously they were abused, but they witnessed the domestic violence. And mom felt like since dad left, Pedro was blaming her for dad leaving and was really angry at her for that. She also had been feeding him through a syringe because she found that the only way she could get him milk was to feed him when he was sleeping or relaxing, watching TV, and otherwise she had a lot of power struggles with him and he refused to eat. She also described that he would pull out the NG tube, and then in order to get it put back in so she could get him the milk, she didn't have transportation. So she actually had to take her other two kids, she had two other kids, a 1-year-old and an 11-year-old, on the bus. And she described these scenes of her with the defiant 4-year-olds, Pedro, and her 1.5-year-old, and the NG tube and the milk, and trying to get to the doctor's office or to the emergency department to put the NG tube back in. She also explained that it was extremely challenging working through interpreters, that she actually did go to a feeding clinic at OHSU one time, but that they had given her these long lists of things to do, and it was impossible to get him to cooperate with any of those things. So again, I ask you to ask yourself, what do you think it's like for this mother when she comes to see you and you ask her about how things are going and you tell her again more things to do? This is a mom who I can imagine felt really hopeless, and she really felt like there was, I know there was the things that people were asking her to do did not, she couldn't pull it off. So it wasn't a match with actually what her skill set was to be able to do those things. So without going into all the details, we did a lot of validation about her situation, and then we legitimized why she wasn't following through. She stopped going to the feeding clinic. We understood why. She actually said that the interpreter that she had when she went to the feeding clinic was not nice. So here she had, it only takes one bad experience and then she doesn't want to go back. They're giving her recommendations for things that she's trying and she can't pull off. She felt like the interpreter wasn't very nice. She also felt like there was a misunderstanding often, and that she didn't feel like they knew what she was saying, and she didn't know that she was always getting what they were saying. So we did a lot of validation and legitimizing why she wasn't following through, because it was a mismatch between what they were telling her and the reality of where the rubber met the road in order to try to get Pedro to do these things. And then we reassured her that we wanted to be able to get her the help that she needed. And when we did the question assessing basic needs, it actually turned out that she did not have all of her basic needs met. And she really could, there were more social services that she could benefit from, but she didn't have access to a computer. And she had been referred to different websites to be able to fill out paperwork to access those services, but she felt like it was impossible for her to do it on her phone. She just couldn't do it. And she couldn't take her 3 kids in tow to the library to easily fill those things out. And honestly, I think she felt like she was just getting by every day trying to figure out how she was going to keep her kids fed. So let's see. Then we had to figure out what we could help her with immediately. And this is where, again, you have to think about the workflow in your office. You have to figure out who has the time and can take responsibility to do some of these things. So in niche, we have one person who does these things, and you may need to figure out one day a week where someone in your office, or if you're working as part of a regional care team, someone takes responsibility and then is available to check in daily and actually do things for mom and with mom, because at this point she isn't in a position to do things herself. Anyway, I just want to say, I hope that I'm like sending home the message that when you really understand the full lived experience of these families, I think you can understand why it's so hard for them to follow through with the things that we're asking them to do, even if the thing that we're asking them to do is so small. And even if we know that if they do that thing, then they're going to get help. But she did the thing and it didn't go well and it wasn't helping. So in Pedro's situation, what mom actually needed was really in the why. Why wasn't Pedro eating? And she needed scripts for how to interact with him to get him to eat. She didn't need just PCIT. That wasn't going to do it. She needed scripts of how to run meals, of how to set clear expectations with him, and then what to do if he wasn't following through. And that was the why for her, and that's what we addressed with her. And we did a lot of follow-up, checking in and out of meals to see how it was going. All right, moving right along. Here's one more. Do we have time for one more case example? Okay, we do. We got time for one more. Okay, this is a 14-year-old boy who was referred, who Joseph had cystic fibrosis. What the provider saw, the tip of the iceberg, was that the family was living in poverty, that mom seemed like she was not on top of supervising him, doing his CF treatments, which were multiple times a day. And people felt like she was rough around the edges. And because of that, she had a really strained relationship with the medical team. She was a single parent and unemployed. She had 2 other children, and he was getting sick. Joseph was repeatedly hospitalized 3 times in 1 year for cleanouts, lung cleanouts, and his lung functioning was really declining, and people were really concerned. As you can imagine, if you're coming to the hospital 3 times a year for 2 weeks at a pop, he also was not going to school consistently, and this family had also been referred for counseling services, and they weren't engaging. So go back to our prescription here. We got a bunch of information from the provider. We figured out a frame for how to talk with mom to get more information. We were really, really understanding and caring, and really approached with curiosity about what her experience was. Without going into the details, again, what we learned about this family was that mom was working on, in the moment, right then, getting out of a DV situation. She had actually been in multiple DV situations with multiple partners. Her children had witnessed the domestic violence. She had PTSD. Joseph had a sibling with autism spectrum disorder, and Joseph had witnessed his older brother try to hang himself 2 months prior because of his own PTSD from witnessing the domestic violence. Mom was now, they were couch surfing, because when mom moved out of living with the partner who had beat her up, then they didn't have a place to live. So she was couch surfing with her children and at the same time trying to pull herself out of poverty. And she was in school for nursing. So she was going to community college. Now, when you think about the tip of the iceberg and you think about just seeing that here's a gruff mom who has a strained relationship with the medical team because she can't get her kid to cooperate. Meanwhile, she is really living moment to moment, trying to figure out where they're going to sleep that night, trying to continue to keep up with her schoolwork so that she could break the cycle of poverty, and trying to take care of one son who had this terrible PTSD and an attempted suicide. And she has this kid who has 3 times a day treatments for his cystic fibrosis. It's an impossible situation for any parent. So while the medical team just saw, how come she can't supervise him in doing his treatments, when we understood the base of the iceberg and got the full picture, we saw why she wasn't able to follow through with the referrals that we believed she so desperately needed. Again, when we validated and legitimized and reassured and then asked about the basic needs, that was actually when she shared that she was couch surfing at that point. And then we thought the thing that this mom needs immediately is she needs housing. She needs stable housing. And in that call, we said, we're going to do everything we can to make that happen as soon as possible. And we're going to work with you to get you on the Section 8 housing list. We're going to work with you to figure out, we actually ended up working to get some funds for temporary housing for her until Section 8 housing came through. And that's what she needed. In this situation, it was obvious we could not address Joseph's medical needs until we first addressed her basic needs and made sure that the family had their basic needs met. So I think that it wasn't easy, as most of you probably know. Dealing with housing issues are really, really challenging. But I hope that sharing these examples helps to, build compassion and help you see that if families aren't following through, there are always legitimate barriers. And you have to be patient, kind, and caring and approach families in some of these nuanced ways in order to get the information about the base of the iceberg, to understand what those true barriers are, and only then can you actually get them to engage in the services that they need. So there are 2 main issues here. The first one is there's always a big context behind every patient. Those social determinants of health, those generational impacts of social inequities, bad experiences with the healthcare system, those are usually present, and you have to keep that in mind when you're calling to try to get information. Assume that families generally have felt blamed and judged, and that parents already are beating themselves up because they feel like they're failing and they're embarrassed. And so you want to, if it feels like in these examples, the level of reassurance and validation and normalization that we suggest, maybe it feels over the top to you, but honestly, over the top is what these families need. When you've had so many touches with a system or with schools or with other people who are trying to help, and you've not succeeded in following through, and then you go back to see them and then they ask about that and you feel like a failure, you need people who can be that reassuring and that kind and that validating and that understanding. So if it feels over the top when you're doing it, you're probably on the right track, that's what those families need. And then the other thing is that some of the problems lie in our own faulty perceptions. It's really easy to make assumptions about things that just aren't true about why families aren't following through. So in order to engage families, we have to always assume that everyone is doing the best they can, and that if they aren't following through, there's some barrier that you don't know about. So that leads nicely into the fundamental attribution error. This is a psychological principle. It fits in my area of expertise. And that's the idea that when good things, or when there's positive or negative outcomes for ourself, we typically attribute those to our personality and personal characteristics about ourselves. And when there's a negative outcome, we usually attribute that to the circumstances. So if I'm in a really bad mood one day, and I have an interaction with somebody at work, and somebody says, wow, like whatever the thing is that I was irritable around, I can for myself say, yeah, but I was late because there was really bad traffic on my way in, and I got this call from a family member because they forgot their lunch at school, and then I had to go and do that, and I was rushing all over, and I was super stressed. And so there were circumstances that affected my behavior in the moment. But this fundamental attribution error is that when it's somebody else that is having a negative outcome, it's easy for us to attribute that to their personality or characteristics about them. So in that same scenario, if somebody else shows up to an appointment and they're irritable and late, then you might think that's because they're irresponsible, and because they're kind of, I don't want to say nasty people, but like generally gruff and angry. So it's something to always keep in check, is when you notice yourself having negative attributions towards someone, to keep in mind this fundamental attribution error, that generally, if it was you that was having that outcome, there's probably some good circumstantial reason for that to be happening. So I always like to keep that in mind. And when I hear providers make dispositional character judgments about someone, I usually like to reframe that. And I usually say, like, yeah, there's got to be a reason. Like, everyone's doing the best they can, truly. And I really think it would be great for us to try to figure out what that reason is. So another one of those concepts to steal from psychology is that the expectancy theory. And this is another one of the guiding principles that we use in niche that I think really affects our ability to engage those folks who don't want to pick up the phone or engage. In 1963, Robert Rosenthal did an experiment where he randomly assigned rats, just typical lab rats, to two different cages, and they were identified as maze dull and maze bright. And then he had lab assistants take these dull and bright rats and send them through mazes. And lo and behold, the rats that were maze bright completed the mazes more quickly than the dull rats completed the mazes. And the reason, you might ask yourself, how could that be? Why is that? And usually, if I were in a training, I would ask you, why do you think that is? And the reason really is because of the way that those rats are handled, the way that the research assistants talked to them, the ways that they actually handled them. And I think that it's important to keep in mind that our families are the same way. When we have these judgments about caregivers and about families, it impacts the way we handle them, the way that we interact with them, and the tone of our voice, and the kinds of things we say, and it's perceived by families. It affects the outcome. So I guess the lesson here is that in niche, we consider everyone a smart rat. Everyone is capable, and everyone can follow through if people understand what the true barriers are. And if we approach everyone with that legitimizing, that's a super important part of our little prescription for getting information. When people feel like you're legitimizing why they're not doing the things they're doing, we're treating them like smart rats. So everyone's a smart rat. Couple of take homes. This is just you might catch yourself thinking this way. If you catch yourself thinking this way, it's all about shifting your perspective. It's never that parents just don't care. It's never that parents are lazy, they're dysfunctional, incompetent, or they can't do it. It's really that families are stressed and overwhelmed. It's likely that they have been mistreated and they're distrusting, or they feel like they've tried and the services don't match what they need. So why would they try again? It's not that they don't care, it's that they don't have the resources to do what we're asking them to do. And it's not that they don't care, but it is possible that they haven't been taught the skills to pull off what may seem simple to us that we're asking them to do. So addressing the barriers to get families the help they need really comes down to putting on a new lens. And this changes the way we interact with them. This new lens is how you end up treating everyone like a smart rat. You have to get the way that our lens affects the way that we talk with folks and the way that we engage with them. And we have to engage them in the right way in order to have them trust us, to have them share the full story, the base of the iceberg. And only through understanding the base of the iceberg can we address those barriers and get folks the help that they need. And I'll just say, there are always barriers, and it rarely is dispositional things. It may be skill deficits, but skills can be taught. So let's see, here's our prescription. This is the take home. The take home is that if you find that you have a family who isn't following through with the referrals for the services that you feel that they need, ask yourself these questions. What are the expectations of the family in order to support their child? What are the expectations in order to be able to follow through on the referral that you've made? What are the resources that are required to do that? And get information about what the true challenges families are facing. What is their real lived experience every day? And what are those barriers to meeting those expectations? What kind of support does the family need in order to overcome those barriers? And ultimately, who's going to take responsibility and scaffold that support? Who actually is going to be the one to call the day before the appointment and do the warm handoff to whatever services it is? So when the families go in and hit those services, that they feel cared for from the first time they come in. Because when you are overwhelmed and living in survival mode, we really don't have the luxury of having a bad experience on the first day that people hit those services, or they simply won't go back. And if you do all of those things and families still aren't able to engage, you can always refer to niche. That's what niche is there for. Not everyone can have niche. Like I said, we had 300 referrals last year. We only admitted 85 patients into our program. That leaves 220 patients that need your expertise and your time and commitment and compassion and your shift in perspective in order to help them access the services they need. So the last part is just this little activity that I wanted to walk you through. This, I encourage you, feel free to play spent on your own after this to see if you can beat the game. But play spent is intended to give you, it's a build your own adventure kind of a game to give you an idea of some of the impossible decisions that families who are living in poverty, families who are dealing with a ton of social complexity are faced with every day, and just to kind of send the message home. Okay, so we're gonna play spent. So I'm going to walk you through an example of what it's like when you're living in poverty and you have to make decisions about what you're going to spend your money on every day. And let's see how this goes. We're going to accept the challenge. So we're going to find a job because we need a job to start off with. You're running out of money fast. It's time to get a job, any job. Here's what you can choose from. So I can choose second shift. That's got rough hours, but let's see, how much money? That's $9 an hour. I can choose that one. Stay healthy. All that lifting and repetitive packing can be brutal on my body. So I'm going to make $306 a week. So as you can imagine, that's not going to get me very far. The Affordable Care Act requires me to get health insurance. The good news is that my child is covered by the state. That's good. The bad news is that I'm not. Which plan do I want to buy? Well, I don't make a lot of money, so I'm not going to do the gold plan, and I can't really afford the silver plan either. The bronze plan, although that seems like a good one, still has me really tight on cash. So I think that I'm just going to opt out, and I still have to pay if I opt out. I actually have to pay if I opt out. Well, honestly, I feel like I need to opt out. So the penalty for not buying insurance is low compared to the cost of coverage. It's no surprise that low-income workers like me opt out altogether. Yeah. Your head is pounding and you're burning up, but you have to be at work in an hour. What do? I got to call in sick. I got a fever. Since your company doesn't offer sick leave, that's going to cost you a day of pay and count as a strike on your record. Hope you feel better tomorrow. I got a job strike now. I don't want to lose my job. You sure you weren't speeding, but the cop gave you a ticket. He disagrees. What do you want to do? Well, if I contest it in court, I'm worried that I'm going to have to take another day off work, and then I'm going to get another job strike. So now I got to figure it out. But it's $250. I don't think I can afford it. I think I have to take another job strike. I get the ticket dismissed, but I still had to pay $50 court fee. All right, well, I saved money. Oh no, oh, I did get the job strike. Oh good, I got a payday. Your credit card kept you afloat while you were trying to hold on to your home, but even the house is gone. The balance isn't. What do you want to do? Oh geez, that's a lot. If I ignore it, it's probably I'm gonna get charged more in interest over time, but I don't think I can afford it and make rent this month. I don't know, should I be responsible? Okay, I'm gonna be responsible and pay the minimum. If you continue to pay only the minimum, the interest you have means it will take you 17 years to pay off my credit card. That's insane. So it's payday. Look, I got some money. I'm doing pretty well this month. Answer or ignore? I'm going to answer it.
Hi, I'm calling from Consumer Collections Corp about the overseas charges on a vehicle in your possession.
What do I want to do?
Hello?
Hang up. If you don't make the payment, your car could be repossessed. Oh no. Your car loan, $500 to make this go away. Oh no. On the way to drop off your kid at school, something blew in your car. You don't know what's wrong. Pay to fix it, get it towed, leave it, and take the bus. I kind of need my car. I need it to get to work. I live really far away from work. I feel like I got to get it fixed. Your child has been identified as gifted and invited to the school's gifted program. The materials are going to cost me $50. I'm going to apply for a scholarship. To get the scholarship, you have to meet with a counselor in person, which could cost you half a day of work and earn you a job strike. I can't afford that, then I'm going to lose my job. Oh no. You've missed 3 days of work, which means that I won't get any more paychecks. Okay, look, I only have 6 days left, 5 days left in the month. My mom needs crucial medication, but she doesn't have the $100 she needs. Well, I don't have it either. That's tragic, but I cannot help her. Trying to keep your family afloat is wearing you down. You think you might be depressed. I don't have a choice because I can't afford to go see a therapist and pay that copay. Another reason why oftentimes families don't get the help they need is because of those copays. You've been experiencing sharp pains in your chest and your family has a history of heart problems. Oh gosh, I can't afford getting it checked out. It's a dangerous decision. Heart disease is the #1 cause of death. You made it through the month with $83, but rent's due tomorrow. My rent was $779. I'm not sure what I would do. Anyway, that's it. I played spent. It's obvious. I hope it gave you an example. I encourage you to try taking the other 2 jobs. I think that they give different examples of those kind of decisions that families have to make every day. Again, this showed 30 different situations that I was faced with every day where I had to decide what I was going to do. You saw the way making some decisions affected my job, and I lost my job. You saw the way it affected my child. You saw the way it affected my social life and my own personal health. So anyway, I think this is a good activity to help you truly understand what some families are dealing with in and out of every single day and what some of those 2 challenges are. So I guess that's my take-home message for you today. Thank you so much for joining me and for listening. As I said, it's possible you already know many of those strategies, and if you do, great, it was a little refresher for you. And if not, then hopefully you can consider some of those strategies when you're most worried about some of your patients, or you're just a little worried, but they're not following through and you don't know why they're not following through. I hope you all have a great day and stay safe out there. Thanks so much.